I'm supposed to be recording this meeting because Chief Olson and I are going to go over this meeting together tomorrow, because he couldn't be here today because I think he's in the middle of labor negotiations. But it is good to know that the data system that the sheriff's office using is the same one. And I think I can speak for Amy and Lisa and say that they really appreciated getting both the sheriff's office and the police department's data from Brett, who pulled it out of the same system. And so it really made lives a lot easier as we were to have that right. Okay.
Absolutely.
All right.
Absolutely.
So thank you very much, Brett. Going on to Jolene.
Good afternoon, Jolene Crone, Deputy Administrator, Clinical Director with the Salish BHASO. We don't currently contribute to this data as we are administrative, and Jim's team does that, but there is some possibility that we possibly could. We have access to some of BHDS, the Behavioral Health Data System at the state level, and could provide possibly some comparison data for Jefferson County versus the 3-county region, that kind of stuff, if that comes of interest. And then we're overseeing the REAL program, so there's a lot of stuff still in the works related to that data. So I don't know that we would have a real clear answer, and we would be working again with Jim's team on the best way to make that available.
Okay, just so you know, we're excited to get it whenever we figure that out, and want to work with whether it's you or Jim to do that, you know, as soon as it's possible. Hopping over to Dunya.
Hi everyone, Dunya Fo at Jefferson Healthcare. Adam is really the person who pulls all the actual information, but it comes out of Epic. So if you don't mind, I'll hand it to him to talk a little bit more if you have any questions about the details.
Sure, thank you. Go ahead, Adam.
Hi, I'm a data analyst, Jefferson Healthcare. Yeah, we pull our most of our data from Epic. Sometimes we try to leverage outside sources like the census and whatnot to compare with, but yeah, for our meat and potatoes, it's all from Epic, our ED, emergency room arrivals, and sometimes inpatient primary care, so office visits with patients with their doctors, things like that. The biggest places where patients come into contact with the hospital, and we try to work with them.
Okay, thank you. Jim Novelli. It's so rare he's muted.
I like it.
Go ahead, Sheriff Noel. You
I got it. I'm
there
done.
We go.
Actually, I'm at this. My second monitor broke down, so I'm not used to working on one monitor. So I've got four things going on one monitor. So it's really hard. So excuse me, but most of our data is collected through our CareLogic system. So which obviously generates and can spit out lots of different things, whatever we ask it to do. We can format that mostly. So it tracks everything we do here in the sense of number of services provided, types of services, who provided the services, so, as we get forward on this and what you want to do, we can maybe modify and change some things. And as Jolene says, when it comes to the real team data, I was going to leave that up to the ASO to figure out how to, I was going to defer to them before I said, oh yeah, we can share that. So, and I know we have some data that Stephen, who works for the Sheriff's Department, well, works for us, but is employed at the Sheriff's Department over there, is using a data system to put data in the Julata system, correct? And that collects data. And I don't know, again, that is a proprietary system. I think that WASPAC lets you use, and don't know about how getting that data from there. And Stephen's been collecting a lot of data in there because I saw some of that. So
There he is. He's sitting there listening.
Yeah, I know. He was just over here a minute ago. So
Well, hello, Steve.
I can see him. So he's busy putting data in, I can tell. So
what I hear is there is a data system that Stephen is using, And it's not particularly tied into the data that Brett gives us, but it is relevant data to the BHC's, desire to understand the whole system. Do I have that right?
And I might be able to comment on some of that. And so can he, actually. He can hear that. But he does review our system too. So I know that some of that gets put into that system. So if you want to comment, go ahead.
So I missed out on some, I wasn't actually paying attention. So what was your question?
So what we were doing was exploring among these, all the folks you see on this call belong to different agencies and organizations that touch the behavioral health system. And in our desire to understand the behavioral health system, each of these agencies is pulling data out of their system that help us understand encounters of, how many we have of this, that, and the other thing. And it sounds like you are collecting some data in your role as a sheriff navigator. And I just am interested to understand if there is data there that we would be able to access that might be illuminating as we're trying to understand the whole elephant that we've got between all of us. And if there is, we'd be excited to get whatever data that is. And I don't know what it is. Between you and Brett, you may be able to identify what makes sense to share in the context of this group, and not at this moment, but as we collect the data on our 6-month intervals.
Yeah, I'm sure that's a question either Sheriff Knoll or Jim Novelli can answer. I'm just inputting the data into the sheriff's CAD system and into Gelada, which is the system being used to collect data for WASPEC and the grant that I'm working under. So if they want to divulge or share that information, that's up to WASPEC, I'm assuming. So, and to, yeah, go ahead, Joe.
Well, I guess I think, I don't mean to speak for Lori, but I don't, is the data you put in Gelada, that's the same data that you would put in New World, am I correct?
For the most part. There are instances where it's not an official sheriff's call, but I go out, say with the real team, and help them with something because they've called and asked me to assist them. So, but because I'm working under that grant, I'm trying to account for all my time. So sometimes, not a lot, but there are times that there's information in Gelada that does not relate to a case number through the sheriff's department. But there will be a subsequent note put in also, I'm assuming in CareLogic, since the real team is working under DBH. So there's notes being collected, but at this point, as related to my activities, it could show up in either CareLogic, CAD, or Gelada. I hope that answers that question.
Well, I'm very excited that our data people have heard all of these explanations, because then we'll be working with them and you guys to figure out what makes the most sense. Because we don't want to load you up with requests beyond what we need from you, but we want to get as much as we can to create as complete of a picture as we can. So we've at least laid the groundwork of understanding where all of the places are that we're putting data in.
Yeah, but the primary amount or the majority of my information goes into CAD and Gelada at this time.
Okay, all right. Thank you so much for punting that entire conversation.
No problem.
Adam looks pretty serious. I think that all data should be funneled to Adam, and that he.
Because he looks like he could handle it, doesn't he?
Yeah.
No.
However, his boss says no. Okay. At this point, Lisa and Amy, what makes the most sense? Should we go with the questions, or should we sort of go through the data and let the questions come up? I can show the slide that shows the questions I think are going to come up. Maybe that's a place to start. Sorry, trying to find.
Sure. I'm trying to look at time and think how much time we have. Yeah, do you want to, I don't know, which is better. Do you want to just start with the questions? And then Amy.
Yeah, and then if we need to refer back to the data, maybe we do
Yeah.
that. Does that make sense? Okay.
That sounds
So can folks see the overview of questions that I think have been coming up in the course of our conversations about this data? Lisa, Amy, I'll let you take it away from here.
Yeah, so the first question we had really came up at our last meeting because we've been presenting for quite some time the behavioral health data from different sources, East Jefferson Fire Rescue, Port Townsend Police, Jefferson County Sheriff, and it was just related to their behavioral health calls. And then, we had a couple questions and there was a couple, I think, other places that were talking about the percentage of their calls that were actually related to behavioral health. So we looked last time, we looked at what's the percentage of actual calls that are resulting in some kind of behavioral health incident. And the percentages were very low, much lower than you'd expect. And so one of the follow-up things we just wanted to talk about is how do we really understand what that means is in terms of the resources that these types of calls are taking. And one of the things we talked about was looking at how many of those are just pure traffic stops. Is there some other way to look at that data so we're not just assuming that it's just this tiny thing that doesn't really impact resources and time and something that doesn't need to be addressed. When you look at 1%, it seems small. And so we were trying to figure out, do we want to parse out the data so that we take out traffic stops? Do we want to look at time per type of interaction? What are the things we could look at to kind of drill down on that more and understand what it's really saying without just like making some assumption that, it's only 1%. It's not and I'm just throwing that number out there. I don't think it was all that low, but they were low. So I just love people's feedback about what are some options. Like I said, we talked about trying to parse out traffic stops differently. Although I'm sure there's some of those that obviously have substance involved in them, but or is it more understanding what those different types of stops contain as far as resources, time, those kinds of things. So I'd love just some responses to those questions. If anyone has thoughts.
Maybe Brett is the one most clued into what. Oh, he's on the phone.
Oh, well.
That's what I would say. Brett would be the one. And me, I don't know. Well, yeah, I was going to say David, but David doesn't deal with that part.
One of the things is what information would be helpful and then what information is available, because I don't even know. Sorry, Brett, we put you on the spot while you were.
I was half listening and it's one of those calls I couldn't put down. So I was like half
listening.
listening.
The basic question.
I heard the traffic stops and whether to remove them.
Yeah, it's this question about, we looked last time for the first time really at what are the total behavioral health calls as a percentage of, what are the behavioral health calls as a percentage of total calls? And the numbers across the board were significantly smaller than you would think, just knowing kind of what we know about behavioral health. So two options we considered, and I'd love other ones, is there a way in the data to parse out the traffic stops so we show a more realistic picture, or is there a way to look at types of stops and the amount of time or resources they take, as far as using resources,
And we see Dr. Carl Baum's note there in the comments of perhaps a secondary impression of a traffic stop plus substance or versus traffic and no substance. So now I'll let Brett talk.
Yeah, so this has kind of changed recently, I would say. So rarely anymore are we going to have a traffic stop with any type of substance involved in it. And there's several reasons for that. If it does happen, it'll be recoded as a DUI if the person's under the influence of drugs or alcohol. So it'll be recoded. It won't be a traffic stop anymore. So that data will not be there. So almost all of your traffic stop data is going to be non-drug related or probably non-mental health related, because it would probably be recoded as something else. That doesn't mean there isn't outliers in there, but more than likely not, it's going to happen. And that's kind of changed recently with the way we investigate drugs, I would say. So the data is a little bit different in the last 2 years than it was historically. So
it would make sense maybe to at least look at all stops minus traffic, or all encounters minus traffic, and see what percentage of those are behavioral health related. Would that make more sense than what we did?
yeah, and that's fairly easy to do. So I just need to know, and if you let me know that you want the data in the call type, that in there, the call type will say TS for traffic stop. And so you can parse it out any way you want based on call
okay.
type.
Oh,
And then
that's
all it is a button for me to add you that information. It's not that difficult.
Fantastic.
And I recognize
like that.
I recognize that across the police department and the sheriff, there might be differences in how coding happens, but generally what you're saying applies to the police department's data as well as the sheriff department's data.
Yeah, and I know he's not here right now, but this will be recorded for him, but it is pretty much similar. Our type of work is different because like we'll have like a lot of civil processes possibly in there where the city doesn't necessarily have as many as that sort of thing, but they might have more, other type of calls that are similar. That being said, the way we put the data in is the same. So it does make sense one person doing this because you can get 2 or 3 or different opinions on how to pull that data out, and it might look different. So that's why on Lisa, the last one you got was more, I guess, organized.
Yeah.
Is because I pulled it all out and then parsed it by ORI number, which was which number the PD is versus us. And it was able to line it up better for you. We never did that. I don't necessarily have permission to do that from Port Townsend. I'm sure they'll give it to me. But that's why that last one looked a little different, because I went ahead and pulled their data and with ours at the same time and sent it to you.
Yeah, that was really nice.
So between the sheriff and Brett, are you both okay if in my meeting with Chief Olson tomorrow, if I ask him if we can have permission to do it that way in the future, where you, Brett, are the one pulling the data for both agencies and giving us?
Yeah, it's literally takes absolutely 0 time for me to do both agencies.
Don't
So
say
it's the
that.
same.
It's hard. It takes.
Yeah,
I
it's
will
the
let them
same
know,
buttons.
though, there will be payment exacted.
The hard part's doing it, but the separating it is super easy. It's just a button. So
Okay. Lisa, do you want me to share back so we can see what the next
Well,
one?
I also, I saw Dr. Carlborn talked about, he liked the idea of time. I don't know, do we still need that? Would it be interesting at all? And is that something that's tracked, the time that's spent on calls with different types?
So that is tracked in us. It's a little more full of errors. So it's not as accurate. And that's basically because we have a lot more buttons to push, the dispatcher does. Sometimes guys are on calls for longer than they actually, like report writing time. They can still be on the call and be sitting there writing the report. So it went, a call went from maybe 10 minutes, a normal call, but it took them an hour to write a report. And that's going to be not very consistent, just because some reports take longer than others. So I can give you that data, but it's a little harder to weed through.
Okay, so it's not necessarily going to reflect. Oh, go ahead.
Yes, it's a little more difficult, I would say, but it's there, and we can certainly present that, and you can do with it as you may. But they call it the on-scene time, probably. So it'd be the time the deputy arrives and the time the deputy clears. But like I said, it's to say that that's indicative of how much time they actually spend on the call it's kind of hard to do.
Is there a way to stop that? Or, could the deputy do something to where the call would end when they're actually done with it? Or
And there is, and we do that. It's just, it's not, like I said, it's depending on how the dispatcher does it and how the dispatcher keeps them on the call and what status. So you've probably seen in our system, Sheriff, where they go from, I have a status as available, and then they have a status as reports. Well, that's what starts the timer. And sometimes they're not very good at doing that. You know what I mean? Because they're dealing with other things. And that's something that their laptop in their car is the only way that they can do that. So if they're outside of the car, they can't do it. They don't have connection, they don't do it. And simply if they forget, they don't do it, which is pretty common. I do that myself. I mean, it's kind of hard to remember, like when you're switching from on-call time to actually doing report time. So it's not as accurate as I would hope.
So when they clear from a call, it doesn't automatically count that.
Yeah, the best, most accurate times you'll get, it will be the time that the police was dispatched, that'll be accurate, and the time the police cleared the call. Those two will be pretty accurate. But the amount of time actually spent on the call won't be as accurate because it's not going to get probably that report writing time or anything else in a very accurate manner at all.
Okay.
Thank you.
It'll be consistently inaccurate, I'll tell you that.
That works.
Okay.
I guess I had a question, Brett. A lot of the data that we're trying to pull together and I guess draw ties between are also, I guess, like bookings that are related to behavioral health and substance use. And I know that our numbers don't always line up between, well, what I would categorize behavioral health booking versus what you guys have flagged it as. And I don't know if the data you're pulling indicates whether or not the individual was arrested and booked.
Was arrested?
Yeah.
I could pull that, but we don't pull that currently.
Okay, I'm just trying to think if there's a better way to make sure that we're accounting the same individuals.
Yeah, you certainly could do that in our system. We would just have to, it would show like what the call or the incident number would be, and then what the call type was, the clearance code. That's what Lisa and Lori are looking at for us, is mostly that clearance code of MH or V Victor is drug related or mental health related. That's the thing that they're kind of looking at. So there won't be necessarily an offense tied to that. Most of the ones that you have, David, are offense, or because you have to have committed a crime to end up in jail. So there's always an offense with it. But for deputies, 90% of what we do don't have a crime attached to it. It's just contact. So that's the only way that we can reliability categorize mental health or drug related stuff.
Just for example, you have somebody that they would have probably had a contact with, flagged it as a mental health or behavioral health issue, and then booked them for criminal trespass. Like, I'm not going to probably catch that unless they say, yep, I've got a behavioral health issue, or our staff are able to identify that. And so that one would probably not come up on our side for data as a data point.
Yeah, we could work on that and make that, because what you could do is look at your bookings and your incidents and look at the clearance code in that incident, and that will populate for you on your side. So it's a little bit hard to find out, but we can work on that too. Or it's something that I can include in my reports. Really, we're in the same system. So you and I just can get together and make a query code. And then once it's created, all you do is every month change the parameters and hit go. It's pretty easy once it's created.
That might also help with issues of duplication that we've had as well. So we can see which patients are not patients, which incidents are ending up in the jail and which are the same. It sounds like you would know which are the same people then under that scenario, right? So we're not double counting.
Sheriff Noel, I saw you had a thought.
Well, David was kind of, we've talked about this before, and I think he was talking about what I was going to say is, the patrol could contact someone and there's definite signs that they have a mental health issue, and so it's coded as that, or the clearance code, and then they go to the jail because they're arrested. And then I think, correct me if I'm wrong, David, but in the booking process they'll ask, do you have any mental health problems or something, and they'll say no, there's nothing wrong with me. So there you have the same person. And so I'm thinking, well, so what? But if you compared the jail against patrol, you'd have it wouldn't add up.
Right.
Yeah, and what you're also looking at there is in patrol, I don't want to use this word as diagnosed, but You know, if we have a high likelihood that it's mental health or drug related, regardless of what they say, it's getting coded as a MH or VP. But in the jail, they're dealing with merely what the person says, right, David?
Right.
So if he says, I don't have a mental health problem, and they're kind of like, well, he kind of does, it's probably still going to be no. Is that correct?
Unless it's somebody that is quite obvious that we know.
Okay.
We'll typically mark it as a no.
And I would say that's even the same on patrol. I remember when we first started talking about doing this, I don't even know how long ago it was, but the idea that, you know, the deputies aren't trained psychologists, but it's like, that guy seems like he's got a mental health problem. So they would code it as that. And the thought was, as we advance, somehow we'll figure out a way to be more accurate. And I think that's kind of what this meeting is about. You know, how can we hone those things in? But we're still relying on the officers to make an opinion based on their experience, which is probably a pretty good opinion.
Thank you. I know our time is flying by here, and I want to make sure we get to the EMS side of the house. Go ahead, Lisa.
No, I was just thinking the same thing. Those are great
Go for it.
conversations that I would love to, yeah, continue those on as far as how we look at that data and how it's coded, because it comes with EMS as well.
So maybe we go over to talking about the EMS side of the house, and we've got Dr. Carlbaum here, so we've got a new player. Dr. Carlbaum, you've seen some of the discussions that have been going on at the BHC. And as you think about the data that you know that you have, and you hear some of the discussion here, I think you have a sense of where we're trying to get to in terms of understanding. One of the thoughts that you offered at one of the last meetings was this idea around developing coding guidelines for at least EMS, but maybe it would make sense across the board.
Yeah, I think, you know, when I looked at, I just looked at one agency. When I looked at their data, there was a lot of behavioral health calls, almost 10%, but not always the primary reason. And so, for example, someone who takes too many pills, the primary diagnosis or reason, impression is what it's called, would be an overdose. But the reason they took the pills is because they're suicidal and it was a suicide attempt, then that's clearly a secondary impression. There's not been clear guidance around primary versus secondary. I think they do have multiple secondary impressions they can put in, and I think they've been told, at least at one agency, not to use those. Although, despite being told that, they're doing it. There were 368 primary behavioral health things, and it's a big list of things I found, and 128 secondary impressions. So I think it happens, and I think we just need more clear guidance. And I guess look for, I can give that guidance and recommendation to all the departments, and I guess I would just look for the data group to help me out. In ESO, I basically went through and there's a couple canned reports, and I just checked everything that seemed behavioral health-ish, whether that was a methadone overdose or psychogenic shock. I'm not sure what that is. And I'm an ICU doctor. I don't know what that is. Intentional self-harm, etc. So there's lots of different choices, and I think many times people just try to find what they think is the best fit, and maybe some guidelines around, for the suicidal patient who is having an overdose, check overdose for primary, check suicide attempt for secondary, check suicidal ideation for third, or whatever, so that we can make sure that we're giving you guys the correct data, because I think it's incomplete and undercounting.
How could we support you in that guidance developing?
I guess maybe defining the boundaries. I could send you the list that I pulled out of this chart, but maybe if you could say yes or no for some of these things. Like, I'm not sure if you want everything, like inhalant related disorders. I presume that was huffing. I'm not sure. Thinking about helping me just, give clear guidance around, these are the buckets that we definitely think are behavioral health and these are not, maybe. And then maybe aligning with Jim and his group about what's the order that things go in. So for the suicide attempt, is it the pills that go first and then the attempt and then the ideation, or is it the other way around? Is that primarily suicidal ideation? I don't think it makes a huge difference. It's just whatever the data team wants.
So Lisa, Amy?
Yeah, it's been interesting because I know the EGFR data, you gave us just primary impression, and it was very heavily, I think this is right, mental health more so than substance use. And so, and we didn't have any data that we were provided that showed if that mental health was related to substance or vice versa. So that would be super helpful if we could. And I'm just thinking, Amy, feel free to jump in, thinking about how to use, we could do it similar to what the sheriff's does, which is if it's, is it just mental health? Is it mental health and alcohol? Is it mental health, alcohol and drug? There's different categories we could maybe create that would say, is it 1, 2, 3, or 4 of these things by looking at the primary and secondary impression data. So we'd have to make sure we didn't duplicate patients, but could look at all of those and identify a patient as how, you know, how many I don't know if comorbidity is the right word, but co-occurring issues are going on with that patient. I think if we had all the data, we could do that, right, Amy? We would just make sure that we weren't duplicating patients, make sure we have unduplicated patient counts, but looking at all of their primary, secondary counts.
Well, I know that data that you sent was aggregated. But if it's less work to do deaggregated data. Just a second.
Maybe mute one of your 2 devices.
Yes, I didn't realize I was actually connected to both until I heard that. But okay, you provided aggregated data in that sample that you sent us a while back. If it's easier, we can take deaggregated data and we could have a row for each encounter or whatever with each of those different buckets. And that would be one way to do it for us, that we could use the data as well.
How deaggregated? Do you need patient name and ID, or is date and time good enough?
Date and time, I'm assuming, would be unique between every single encounter. So that would be perfectly fine.
Okay. I think the other would be hard for me to sell to the departments.
Oh, no, absolutely. I don't want that. I mean, we could even just make up a random number, just sequentially number each row. Yeah.
So I hear the opportunity around deaggregated, and we still want to do where Dr. Carlbaum gets us sort of the range of what he could include, and for the data team to think about what exactly do they want and maybe in what order of priority. Does that summarize well what I've heard here? Lisa?
Yeah, I think so. I think, and I don't know enough about how much it'll change the practice of people, but just having that data to look at, because we had it so rolled up that it was hard. I'm not even sure what was in some of those buckets. So it'd be interesting to see at least the previous data. So yeah, that would be great. I think it'd be really nice to have some people weigh in on that, and then kind of think about, I know it's different types of providers and staff that are encountering people, but it sounds like it would line up better with what we're getting from some of the other entities as far as, you know,
Dr. Carlbaum, I mean, are the EMS staff able to determine intent? I mean, if someone had too many pills or they had OD'd, if it was accidental versus a suicide attempt, because we have them for longer in our emergency room, right? And so the provider can interview and talk to them about that stuff. I just wonder, I would be afraid that potentially, I don't know, the paramedics could categorize every single overdose as a suicide attempt, which is inappropriate.
I think there are some that are unclear, but I think most of the time in their narrative, it's pretty clear. You know, this person says they took the pills in an attempt to end their life. This person this elder often got a new prescription for this medication for their back pain, and they've been taking it and now they're altered. Like, I think it's
clear enough.
Pretty clear. Yeah.
Okay.
I think some of the things like, you know, alcohol intoxication we'll have to think about is alcohol on breath, or what's it called in Jefferson County? HBD. If that's good enough for alcohol intoxication, I think it probably is. But, you know, and then for opioids, you know, just what's the, you know, clear definition, you know, is heroin overdose mean I have to see some evidence of heroin use versus opioid overdose, which is I came and I gave naloxone and the person woke up, but I didn't quite see I didn't see any, needle in their arm, and so I don't know if it was heroin or not. So I think that's stuff that we can work on the training side.
It's also done as a form of domestic violence, isn't it? Like forcing someone to overdose on something.
Mm-hmm.
Lots to differentiate.
Quickly, I wanted to jump back. I apologize, Adam. I just saw that you had a note, and it was back a few minutes ago about easier to identify non-BH visits. Was there something there that you wanted to circle back and pull back into that conversation?
Oh, my comment on the, I just wanted to throw it out there as something to think about and just to ask the question when we'll go back to our work. I don't know anything about police encounter data.
I apologize. I didn't have an eye on the comments like I should have. Okay, Sheriff Noel.
Sorry, for Adam and Dunya, I guess the thought of when you from, I think of Jefferson Healthcare, there's the emergency room and stuff, but then you also have like doctor offices and stuff that are, and it just made me think about, do people come to the doctor's office and all of a sudden it turned into a mental health thing and they get sent somewhere, or you tell them to go to, I'm just wondering if that's something that gets tracked, or if that's even something that we care about.
It happens all the time. Whenever the patient hits a certain acuity level, then if there's any kind of suicidal conversations, then we call Jim's team or we send them over to the ER. But there's often sort of more mild to moderate behavioral health things that come up in normal well visits or postpartum visits or any kind of visits. So, but we do sort of navigate them to the appropriate place for those.
Yeah, and I don't know I guess I was thinking that I start to forget what I'm thinking about, but that this group, when we started working on this stuff, it was just, I understand the impact on first responders and stuff, but as it evolves, it's, I look at it, what kind of a mental health crisis or whatever you want to say we have in our community, that some of those numbers that first responders don't necessarily respond to might be worth looking at as well.
Go ahead, Lisa.
I don't know.
Adam, we have looked into Jefferson's data. You've given a mix of data. Some has been just ED, some has been primary care. I'm trying to remember, and Amy, you can jump in too if you remember. Have you given us, I don't know what it's called in primary care, I want to say discharge data, but referral data from your primary care clinics to show behavioral health or substance use or referrals? Is that something that?
No, I haven't given any referral data, only encounter data.
Is that something that, one, people think would be helpful, and two, is reasonable to ask for or pull?
I can't make any promises right now. We're still exploring quite a lot. I can personally say I want to get in. That'd be super cool to get into it, but I can't.
Yeah,
I can't say too much on it right now.
In my prior life, I work with that kind of data, and it's actually quite, in my experience, it's sporadically collected, and it's really hard to make decisions on, just because of inconsistencies in that type of reporting. But maybe that was just my prior experience.
You mean whether or not they're coding referrals, is that what you, in their primary care, is that what
just getting that data out of Epic can be challenging, and how it's collected.
We have an entire referral database, and referrals are one of our primary big dot goals for 2022. But Amy is correct. It is messy and weird, and sometimes things follow and sometimes they don't. So I would be nervous that those data would be a little bit deceiving, or not make much sense in trying to paint the true picture. I have to jump off, but
Thank you.
take it away,
I
Adam.
appreciate everybody. It's at 2:46 now, so if you have to jump off, you can. If you don't, it would be great to just think for a moment about our real, the pre-mobile crisis team real data, which I know is out there a bit, so this might be a very short conversation. So if that conversation doesn't pertain to you or you're not interested in hearing it, feel free to jump off. And thank you for coming. So let's see, we have Jolene. There we are, and Jim. So I've been alerting Amy and Lisa that we've got this wonderful thing that's going to start up, and it's going to be a new realm of data that we'll start adding. And I recognize it's not ready yet. And I don't know if there's anything that we need to discuss as folks are looking now at forming what data is collected and how it will fit with us, but I wanted to leave a little bit of time here for us to talk about that if necessary. And Jolene, maybe we start with you and what you know about where it's at right now.
What I know, like Jim's chuckling.
I feel like there should be a drum.
I tell you, it's been a fiasco. That's what I know. So we do have specific data points that have now been dictated by the Healthcare Authority. So we are working on processes to collect those in a new, or in the format, but it's like Excel spreadsheet kind of technology at this point. And I don't anticipate we'll see a tremendous amount of change. I have programs I rolled out 5 years ago that are still on that type of technology for some of these newer programs until they can figure out how they kind of retrofit into systems. And then we have some parameters within our contracts about what information we can share, and we haven't even looked at any of that stuff yet. But we definitely are starting to collect, at least contacts, numbers of folks, those kinds of things. So,
which I think is the kind of thing we're interested in. I mean, for the purposes of this group and just understanding our system as a whole. I think that my thought there is we circle back to you, as we're, one of the things I should mention is our next data poll happens for the period ending in February, at the end of February. And then of course, I just got a note from HRSA today saying that they were evolving some of what they're collecting. So I'm just saying that there's going to be a little bit of variability in our next at least 2 data polls, but I don't think it will work. I don't think it's going to impact the data that we're talking about here in this small group, which is specific to Jefferson County's behavioral health system. Lisa, Amy, is there anything else you wanted to mention? I know we had the jail data, and I think David Fortino answered our question at the beginning of the meeting about how they separate. It sounds like their grant data is collected sort of by hand, and then they have other data that's put into that same system that Brett England is using.
I do have one question about the jail data. So I know you have, we have your bookings data, and we talked about that and whether or not we could, and I know we have your, I guess, survey data that you do with your bookings that tells us if people are reporting mental health, the data you've been providing us all along. And then we have the data from Believer in Recovery and Gateway to Freedom, their referrals that they make within the jail. But then this other program is separate from that too, right? The residential treatment program. And I don't think we've ever received data on that piece of it. Is that possible, or is that important?
So that, yes, that data is collected on a quarterly basis. It's basically submitted via a Word doc to the state. I can share that Word document with you, and you can see if there's items on there you'd like to collect as well. It's more of a tally than it is like, trying to track the well, there might be a way to track the individuals to make sure there's not like duplicate duplicates and that kind of thing, but the data that's reported to the state is just a tally. They're not getting a lot of individual
It'd be
data.
interesting to take a look at it if you're willing next go around. Again, we want to respect how much time this takes to pull some of this, but it'd be interesting to take a look at that, just see what it shows.
Sure.
And then my last question is for you, Adam, related to the data you provided us last time that was around your percentage of total ED visits that were behavioral health or mental health. Is there, how is that, I mean, how do you determine which, is that if they had a diagnosis of, so it's not someone that like we're talking about this had been drinking or things like that. Do you catch those things, or is it a diagnosis of a substance use disorder or a diagnosis of a mental health disorder?
Yeah, I've gone back around on that one a few times. I have settled on, there's an organization that's it seems like it's half nonprofit, half private, but it's got all these clinicians and data people who created this called HCUP, healthcare cost and something. I can provide a link if it is, but they provide a ICD-10 grouper categorization tool. And one of the top level categories is mental health and behavioral neurobiological. And I checked the primary and secondary diagnosis for each encounter. And if either of those falls into the behavioral health category, then I'll flag it. And there's subcategories in there to differentiate the substance use disorder versus mental health. And they have all the rationale for why they're categorizing it this way. It's all, yeah, anyway, more than you were asking for, but.
Oh, that's great. And so it is primary and secondary, though. That was one of the things.
Yeah.
Yeah, okay. Okay, great.
TMI.
No, it's not that. I could talk about it for hours, so it's not too much information, but I think we only have a few more minutes. So those are our main questions. I think, Amy, did you have any other questions based on the data we got last time?
No, I think we've covered them.
Anything else anyone else wants to?
Lisa, do you guys measure housing? So housed or unhoused?
As far as the data we're getting from, I don't think we haven't asked for that, and I don't know if everyone collects that. As far as I don't know if everyone can weigh in. Do you collect that at the hospital or in the field?
I have no idea for the field. The hospital should. It might be hard to find.
Interesting.
It is. Yeah, I can speak at length on that if you want, but it's not documented directly. I kind of derive whether or not they're homeless by looking at a variety of factors after interviewing, like registration and stuff, like kind of going by internal behavior of employees and stuff. Like they'll put the phone number as 7777, but for some reason they'll put the phone number all 7 with the homeless. I mean, that's one example. We don't train people to do that or anything, but I've heard someone say that. Anyway.
And what about the sheriff? Is that something you collect?
Well, I don't, Brett would be a good one to ask about that, but I don't know how we would track that. I know, but I do know that one thing we do is when we contact people, if they don't have, one common thing is, what's your name, what's your address? And if they don't have an address, we'll put transient in there. So there would be a way to search that, I suppose, but how that would tie into what case and whatnot. I would be open to any ideas that, if we wanted to, I think that's a good idea to look at that and how does it interrelate with everything.
Yeah, I think that's a great idea.
I would like to say just a little bit more on it, just so I make sure I didn't put my foot in my mouth, and why it's so difficult to track homelessness in particular, because a lot of patients don't want to admit it. They don't want to say I'm homeless. It's embarrassing, and a lot of patients will use put their friend's address, or they just won't say it at all. And we might uncover it through an abuse screening, like saying, do feel safe going home at night, then they'll be in way down deep in there, say, I don't have a home, you know, stuff like that. So it's hard to document. It's not something that you could just, I don't know, show me someone who does a good job at it. I want to talk to them, learn. But yeah, it's really difficult.
Yeah, and I would add to that too, you know, just because someone tells us that's where they live, you know, it's not always that the ID is checked, I mean, depending on what the situation is. And I would agree, some people would, or are embarrassed to say that, just like, you know, are you addicted to drugs? You know, no, of course not. So I want to say one thing that, oh, well, I'm sorry, go ahead. We were still on your topic.
No, I was just going to bring it up because I think unstable housing is a huge risk factor for a lot of this stuff. And I just think starting to gather that data might help break down people's misperceptions around housing. And, you know, obviously I'm a believer that you solve people's misinformation with data. That may or may not work in our modern world, I don't know. But that's my hope. And I just wonder, so I'll look on the EMS side and see if there's a way to document that. I think, you know, stable housing, yes, I have a place I live versus couch surfing versus tent living versus wrapped up in a plastic bag in the woods are obviously on the spectrum, or living in my house, my motorhome are on the spectrum. But I just wonder if there's a way to start to unpack that a little bit.
Yeah, data is good as long as it agrees with what I think. One thing that I wanted to say was, it's almost like I was thinking the more we collaborate, the more muddy the waters get. But when you talked about the real navigator and how they work with our navigator and how they work with the sheriff's deputies, and is there going to be 4 sets of data or whatever for the same exact incident, and how we're going to untangle that. So
that is a very good question, which is why we're so interested in how the real data will fit in. I mean, some of it, at least we might have a chance in heck of understanding if they all kind of somehow are connected to DBH. In this situation, that might put Port Townsend Police Department in an outlier, and that's a pretty significant portion of who we're interacting with.
So our data for the real team is actually going to be what's on the spreadsheets that Jolene is talking about. They will not be entered into our CareLogic system, because to get into our CareLogic system, they have to be open for services. Then these people do not have to get services. It's not a clinical based program. So it's not something where they have to receive services. It's just outreach and give them the support they need and maybe guide them in a direction. So they will not be entered into our CareLogic system. So tracking that information is going to rely on basically hand reports that are filled out by the outreach workers and submitted and put into a spreadsheet. So right now, that's the way it stands. So we could possibly segregate a separate side to our CareLogic system and try to track that stuff. But right now, that's not in the works. So
do we know, Jolene, is the question of housing or any quantification of it, is that included in what real might likely be tracking or collecting?
It is likely we may have some of that data, but again, it's one of those things. It is about self-report. Somebody, you know, just because they're sleeping outside doesn't mean they don't technically have a residence. I mean, if they're only outside when they're using and then they go home, I mean, it really is so inconsistent, but possibly. I'll leave it at that, possibly.
The reason I ask is I know from being on the housing panel that the point in time count is often significantly underreported. And if we had even a self-reported comparison to the point in time count, that might be interesting just to see how close together or far apart those two numbers are, even though we admittedly know it's the accuracy of it is definitely nowhere near possible.
Yeah.
Okay.
But real doesn't like cross over into HMIS or anything like that, where we could really look at kind of the homeless information.
Any other thoughts? I appreciate everybody staying on an extra 15 minutes here. And Lisa and Amy, anything else that you wanted to ask?
I have 1,000 more questions, but I know we already went over time. So I think we can make a list of questions for the next meeting. And I don't know, Lori, if you, how we'll follow up with some of these things. I know it sounds like some groups like the jail and sheriffs are going to be chatting, and I don't know how we.
I think what I'll do is I'll go through and create a solid set of notes from this meeting that sort of outlines all the things that we thought might be a good idea. And then send it out to everybody. I would like to set up another data meeting, possibly a month out, maybe 5 weeks out from now. And in between now and then, get everybody the notes. Lisa and Amy and I will put our heads together about what needs to come next. Maybe I'll meet individually with Dr. Carl Baum, with the Sheriff's Office, with the PTPD. And when we come back to that meeting, we'll have made some progress on some things and ferreted out some other questions that have risen to the top as our top questions to address at that next meeting.
That sounds good.
And
Okay.
I'll check with Brett on the possibility of tracking
Okay.
homelessness, but I just keep thinking about what Jolene said, they're out there 2 days. Does that make them homeless? And how complicated.
Depends on whose definition of homeless you use.
Right.
Correct.
Well, then it's like, yeah, and it's funny. It reminds me of anyway, part of my job used to be tracking sex offenders, and it was, if you're a homeless sex offender, you have different reporting requirements. And this thing about what does homeless mean, and or transient, and it opens it up to all kinds of. Well, I was just camping that week, or whatever.
Certainly does. Yeah. Okay, so does this time slot, so we're at the first Wednesday of the month at 2 p.m. Does that work for folks if I were to set this up in in March for the first Tuesday or Wednesday of the month at 2 p.m.? Does that work for folks? Maybe I'll just, nope, does not. Dr. Carlbaum, would 3 o'clock work for everybody? First Tuesday of the month, 3 p.m. 1 o'clock, going once, 3 o'clock. One would be better, Dr. Carlbaum?
Either. I just have a meeting that's scheduled
Okay.
every other month at 2 on that day.
Okay,
1
so I'm
o'clock.
gonna,
I think we're open.
what did you say, Joe?
1 o'clock's good for me. I don't know how other people. Wednesday is kind of my day to do work, and so throwing a meeting in is no big deal.
Okay, all right, so I'm gonna say, Jim, 1 o'clock works for you?
I'll make it work one way or the other.
Okay, I'm gonna send out a save the time for 1 o'clock. I'm gonna get everybody on it this time, Jolene. And I'll circle back to each of you or most of you individually between now and then. Thanks so much for your time today. This is really a good discussion. I feel like we got another piece of the foundation down.
Yeah, thank you, everybody.
Okay.
Hey, everyone.
Thank you.